So our topic was improving healthcare for lesbian, gay, bisexual, and transgender elderly patients across various care settings. So I think one of the important points is that the majority of our LGBT patients have already experienced significant discrimination along the way in healthcare settings. About 56% of our LGBT patients and 70% of our transgender patients report significant discrimination or mistreatment in healthcare settings, sometimes even outright denial of care. So when we see these folks in a palliative setting, they've already had significant reason to mistrust healthcare professionals or had suffering that came about because of healthcare professionals. So I think it's important for us to try to remember that this has happened in their past and try to do what we can to lessen some of that suffering going forward. Another point that we wanted to bring out was the idea that as some of our older LGBT patients get sicker, get more ill, they end up needing to go to nursing homes and they end up needing to go back into the closet. They had already come out in their regular lives, and now in a new setting, in a nursing home setting, they're feeling for their own safety that they need to go back in the closet. Once again, the majority who have come out have said they had experienced discrimination in those settings. Many won't come out because they fear that either the staff or the other residents will discriminate against them or bully them. And I would say another point was in regards specifically to our transgender patient population, which is especially challenging for some of us who rarely experience taking care of someone who's transgender, and sometimes we just don't know how to go about it. And one of the strong take-homes I would say is that it's important to call somebody what they want to be called. That can go a long way simply by using the preferred name that someone expresses, using their preferred pronouns, and knowing that asking them what they want to be called is better than making assumptions, and will go a long way to starting development of a rapport with them. These are folks that have suffered a lot, and you can easily make a big impact without that much effort. This is relatively low-hanging fruit, and as palliative care professionals, we want to try to relieve suffering. This is a great place to do it, and one you can do so in a relatively easy way.